Hello everyone, my name is Kristie Avon, and this is my presentation for my DNP Quality Improvement Project titled Postoperative Communication Handoff Tool. Committee Chairwomen, I'd like to thank Dr. Jennifer Hepner, who is my DNP Chairwoman, Dr. Rita Wunderlich, PhD, second reader, and Tara Pruitt, who is my community member during and after the Quality Improvement Project. Background and significance. Aims: to implement a standardized communication handoff tool to provide safe patient care and improve staff perception and satisfaction during handoff. The project was designed to overturn the hospital's absence of a policy governing patient handoff. So this scholarly project took place in the PACU department located in a rural community hospital in the southeast region of the United States. Perioperative staff, including anesthesiologists, CRNAs, and OR nurses, provided a verbal exchange of communication to the receiving PACU nurses, and that was the primary problem. Prior to this quality improvement project, there has never been an established policy governing the exchange of patient care from one department to the next, or during nurse-to-nurse handoffs. So the entire purpose of this project was to implement a standardized SBAR communication handoff tool to improve the flow and accuracy of vital information relayed during the handoffs. And you've probably heard the acronym SBAR, which stands for Situation, Background, Assessment, and Recommendations. The background and significance for this project. And this is some pretty fantastic data that communication failures account for 80% of serious postoperative outcomes. Now, when we look at that number, we say 80%. What does that mean? That means 8 out of 10 patients have serious postoperative outcomes. And a lot of that can be attributed to miscommunication or omission of communication. Ineffective and deficient handoffs as primary gaps in patient care, leading to medication errors, omission of pertinent procedural information, and wrong site surgery. As previously discussed, no policy existed at the project site. Documentation from one department to the next relied heavily on self-made report sheets. A structured handoff tool was vitally important to help alleviate the need for memorization, to improve proficiency, and to enhance staff awareness and satisfaction. There's an abundance of evidence supporting ineffective and deficient handoffs as primary gaps in patient care, as I've previously discussed. The aforementioned contributing factors to potential patient harm occurs due to the process of multiple participant handovers, inconsistencies in the formation and continuity of misinformed reporting, and interprofessional false perceptions of limited risk. And so basically that's saying that nurses or anybody giving a report has this false idea that giving a verbal report is sufficient data and at low risk. Review of the literature. Again, SBAR stands for Situation, Background, Assessment, Recommendation. This is the format that improves communication in high-risk handoff settings such as the PACU. It provides a real-time specific dialogue of relevant patient care information. And it's in the data that 74% of nurses felt more included, satisfied, and perceived exceptional transition of patient care from the perioperative department to the PACU using a formalized written handoff versus an exclusive verbal exchange of patient care information. A comprehensive review of the literature was performed to analyze evidence-based supportive data related to the implementation of a standardized handoff tool to improve communication between perioperative personnel and PACU nurses. The findings revealed common overarching themes across the research that focused on different methodologies used and effective strategies employed due to EVP changes on the use of standardized handoff communication tools. Although several tools for the dissemination of information were utilized during changeover, the significance of using a tangible communication tool clearly minimized miscommunication. This type of structural support creates a streamlined opportunity to improve the handoff process, which provides real-time specific dialogue of relevant patient care and diminishes the capacity for inappropriate treatments and care omissions due to the rapidly changing physiology of the patient. So I selected Malis's transition theory as my theoretical framework for this project, and it worked fantastically. It seeks to uncover the risks that are inherent to vulnerabilities. It's a semblance of structure allowing all healthcare providers to responsibly engage. Types and patterns of transitions, properties of transition experiences, and transition facilitators and inhibitors. Throughout the research process, there were many identical themes and concepts that involved the transitional process. Because patients move from one department to another and transition from one provider of care to the next, the conceptual framework of transitions was very much fitting. Malis's theory seeks to uncover the risks that are inherent to the vulnerabilities, as we've just discussed. These vulnerabilities are unplanned experiences, person-to-person interactions, circumstantial upended environmental conditions, and the potential for problematic or delayed readjustments. And the method and design for this project was actually didactic. It was a qualitative and quantitative exploratory design was employed, but it was also qualitative in the beginning when I was eliciting inclusion criteria. And I have a couple slides that show the demographics for that. Participants were actively engaged throughout the duration of the study, and this study used convenience sampling of voluntary hospital staff participants. So normal operations consisted of perioperative staff, including anesthesiologists and OR nurses, who provided a verbal exchange of communication to receiving PACU nurses. The implementation of an SBAR communication handoff tool, in addition to subjective responses from a pre- and postoperative survey, were the instruments utilized in this study method. Researchers have found that structured handoff tools not only increase the reliability of relayed information, but also expedited patient assessment, facilitated swift interventions, and diminished the potential for adverse events. No patient data was revealed, as the project did not focus on patient presentations or outcomes. A power analysis was calculated using the SPSS program, using an alpha of 0.05 as statistically significant. And this was an effort to achieve a power of 80% of the true effects of the anticipated, but pre-intervention n equaled 29 and post-intervention was 21. So this is a sample of socio-demographics that I spoke to earlier. And this is an example of years in occupational role at the project site. And I thought this was pretty important, along with a few other socio-demographic, and pointing out that longevity played a role as far as buy-in for the introduction of a new tangible reporting system. You can see that the preoperative RNs had at least 9 years in their particular role. RNs had about 10 years of length of time, and PACU RNs about 8 years in their length. And there were even and there were employees who had been working at this hospital for 15 to 20 years. And when I say that it's a small hospital, rural hospital, just to give you an idea, there is one floor with a maximum capacity of 20 patients, and they have a step-down / ICU unit which holds up to 8 patients. So on any given day that they're full, there's only 28 patients. But they had that, and they also had the day surgery. And so this kind of I guess was a cross between the patients that were already admitted and patients during day surgery. Data analysis, a z-test for the difference of two proportions in directional formula of chi-squared was used to analyze the data. The Likert style survey answers were evaluated as dichotomous variables comparing the pre and post intervention data, and chi-squared analysis for unpaired data. Quantitative data was used to appraise participants' answers to a 3-question demographic and a 13-question Likert-style survey. The latter analysis resulted in the form of ordinal data, and then nominal and ordinal data were transferred to the statistical software for computation. The 13-question Likert-style survey used in this project was a method for scaling responses, and were evaluated by using an upper tail z-test. The Likert-style survey questions were my personal favorite to use because I really think in general that people answer the questions to the best of their ability. With that being said, there are typically 5 different answers. For example, always, almost, never, seldom, and then there's neutral. And I really felt that during this project that I received honest answers. Just going to back it up here. Analysis, okay. So the results in determining whether there were feelings of inclusion during the patient handoff process. The test that was used showed a p-value that was 0.0004, which was less than the significant level of 0.5 and therefore statistically significant. Additionally, feelings of firm understanding of the goals of care after the postoperative handoff for pre and post interventions, we reject the null hypothesis, which is what we want to do. Um, we want to reject the opposite of what we're looking for. And so in this particular Likert style question, P was 0.0036. It was considered statistically significant, and which was less than the significance level of the 0.05 to suggest a decrease in the ratio from pre to post intervention. Confidence interval estimates of the difference between two proportions, such as whether there's a firm understanding of the information passed over from the perioperative to the postoperative staff. The question of how often one understands the actual procedure performed between pre and post intervention, where we rejected the null, and it was statistically significant. So basically what that's saying is from one nurse to the next, did they really know what procedure was happening, and how well did they actually understand the information? And what this showed was that it was only after using the SBAR handoff tool that they really understood exactly what procedure was being performed. Limitations. The biggest is time constraints, and it may very well have affected the end result of the data. And this was due to condensing the intervention to only 4 weeks after the pre-intervention education. If I had to do it again, I would make sure that the staff had at least 1 to 2 weeks of a dry run. I think that they would have benefited from this dry run of using this tool so that they could get used to it, instead of just saying, here's the education, now do your best. And I think they did their best, but again, these were employees who were just coming off of paper charting and were just learning how to use the computer. So another limitation was just that they were documenting on paper. And within the year prior to this quality improvement project, they went from charting on paper to an electronic medical records. So the big scare for them was, now that they've learned everything that they need to do about electronic charting, were they then now having to go back to paper charting? And so it was a 50-50 split on the big concern about it. But those fears were allayed once, we discussed in huddles, which were very important and very helpful for this intervention, that this was not going to happen. If anything, if they were going to use this tool, it would be an adjunctive tool to what they were already using. We all know that a very important note is that healthcare professionals need time to embrace a culture of change, which may take a lot longer than 4 weeks that are allotted for the project's pre and post surveys and intervention. So now a problem that I ran into, and this was after the first week, when I checked back in and went to the hospital, when the number of handoff tools was dwindling down by the end of the first week, it signaled the need for more education to keep the intervention alive. And had that not happened and posters not been made and frequent huddles not been had, the intervention would have come to a complete stop. While a few more handoffs were received by the end of week 3, it foreshadowed the possibility of limited participant engagement. This may have been due to loss of interest, coupled with the burden of handwritten documentation. So lack of handoff utilization may have been due to competing electronic medical record documentation and quite possibly the duplication of charting. Another limitation was the small sample size, which could have impacted a particular population. All the units in the surgical department had very low turnover rates. According to the study and the answers given, there were people, at least 5 to 6 people, who had been working at the hospital in that very department for at least 15 to 20 years. Discussion on the findings. We talked a little bit about that. They were in line with the anticipated outcomes. The literature supports the findings, and there were not significant improvement rates even after the intervention. And I truly believe that the limitations should be a research focus. The findings of the research study pretty much fell in line with the outcomes, and I had heard from the administration that employees at this hospital have longevity and that it might be very difficult to have them turn around and try something new because they've done it that way for many years. But the literature supports the findings in that if you can get employees who are open to new evidence-based procedures and protocols, you usually have higher rates of engagement. So it wasn't surprising that the outcomes did not show a significant improvement in rates. And this is exactly why, for the future, limitations should be their research focus. This should come with more frequent provider education. And while new electronic medical records have shown to be very beneficial in this new age, there are just certain alternatives that must be put in place, such as a tangible, standardized handoff communication tool, and one that complements the EMR. Implications for practice. According to Pullett and Beck, the results of a study are generalizable when they can be adapted to patients who can relate to care and are proper for informing a clinical decision. Academics must make comprehensible decisions about generalizability of research findings beyond a study population. The design of the tool included the SBAR reporting for surgical patients transitioning throughout the preoperative, intraoperative, and postoperative units. This designated handoff tool would not be of use to other units within the organization as designed. And essentially, it was specific to PACU. A structured, standardized communication handoff tool is associated with increased communication and transfer of information. Conclusion. Again, I'll come back around to communication failures account for 80% of serious postoperative outcomes, primarily during the handoff process. Researchers have found that structured handoff tools increase the reliability of relayed information. Handoff tools also expedite patient assessment, facilitate swift interventions, diminish the potential for adverse events, and bolster healthcare workers' perception of providing quality patient care. And this is the point where I ask if there's any questions, and I know that there's no audience to select, but it has been an absolute joy to be a part of this DNP quality improvement project, and I just can't say enough about the support that I felt, especially from my coach, Dr. Hepner. So I thank you personally for that. See you all at graduation.